Hello, my name is Kelly Foster, and this is my presentation for my genetics project. I chose to do Hashimoto's thyroiditis for my disease. It's a disease that I have. It's actually a disease that my father also has. So I was always very interested in finding out the genetic origins of the disease and doing a little bit more research into what causes it, the specific mutations, certain treatments, and it's always good to be more informed. So that's what we'll be talking about today. Hashimoto's thyroiditis and what the diagnosis means for you, assuming we're presenting this to someone who has just been diagnosed with this disorder. So we'll be covering a multitude of things today, basically just a breakdown of what is the disease, the genetic origin, the mutation and its effects on the gene, the pattern of inheritance, the symptoms and treatment of the disease, and then some resources and support. And then I also included my references at the end of the presentation, as well as in the Word document that I'll be turning in. So what is Hashimoto's thyroiditis? Because of course, when your endocrinologist sits you down and says this big name to you, it's a little scary and you're not entirely sure of what it is that he's talking about. So the diagnosis, Hashimoto's thyroiditis, it's also referred to as Hashimoto's disease, chronic lymphocytic thyroiditis, Hashimoto's immune disease. There's any number of names. It's an autoimmune condition in which the body's immune system attacks its own tissues, specifically the thyroid gland. So the immune system is confused and thinks that the thyroid tissue is foreign or an alien. And the thyroid tissue is a gland that wraps around the trachea in the neck, and it secretes hormones. It takes signals from the pituitary gland, and it secretes hormones that control pretty much everything that goes on in the human body. So when you have this disorder, your immune system doesn't quite understand that the thyroid is part of the body and is not a foreign invader, and so it starts to attack it and break it down. And then the thyroid obviously can no longer do its job. It becomes inflamed and irritated, and sometimes becomes hypervascular, where it's actually creating blood vessels to try to sustain itself as it struggles to survive as the immune system is breaking it down. So typically this will throw the patient into a state of hypothyroidism, where they're not getting enough hormones and they're going to start exhibiting symptoms of hypothyroidism. But typically it will fluctuate between hypo, which is not enough hormone, and hyper, which is actually too much, as the thyroid struggles to regulate itself. So basically, a normal thyroid looks like a pretty little butterfly-shaped gland. It wraps itself around the trachea. There's a left and a right side. A normal thyroid is a couple of centimeters across. It's not very large. Obviously, it becomes enlarged when someone with Hashimoto's thyroiditis starts to exhibit symptoms. It will continue to grow if it goes untreated. So unchecked, it will keep growing, and then sometimes will create what's called a goiter, which is basically like a large growth around the throat. But this won't normally happen as long as the condition is treated in the beginning stages. So the thyroid typically releases T3 and T4 hormones. The pituitary gland is in charge of telling the thyroid how much hormone to produce. It releases TSH, which is thyroid stimulating hormone, to tell the thyroid how much hormone to make. So basically, when you are diagnosed with Hashimoto's, your endocrinologist will do a series of tests to make sure that that's what's actually happening. They'll test your TSH levels, so that is how many signals the pituitary gland has been sending you to create more hormones. So obviously, if your TSH is high, that's going to mean that the pituitary gland is just sending out signal after signal after signal, and the thyroid can't keep up, and it's not making enough hormone. So a high TSH is always a sign of thyroid problems. Then your ATA or TPO levels, which thyroid peroxidase, or TPO, are antibodies that your body will create to specifically attack the thyroid. So that is, your immune system is now actually creating catered antibodies to break your thyroid down. So any presence of that in your blood is not a good sign. And then just your typical free T4 levels. So that's your hormone levels. Are they normal or typically they'll be very low if you're diagnosed with this disorder. Your doctor may also order a thyroid ultrasound. They don't need to do that to diagnose the disorder, but they might, just to be absolutely sure that the reason your thyroid is failing is not because there's some growth or other issue, like possibly cancer or even a benign tumor that might cause it to break down and stop doing its job. So they might also do an ultrasound, but not always. So genetic origin. The genetic origin of Hashimoto's thyroiditis is somewhat vague. There isn't specifically, we've talked about sickle cell anemia, and various other disorders that have been pinpointed over, the last 20 or 30 years of having a specific gene associated with them. The problem with autoimmune disorders is that there's so many varying symptoms that it's very hard to pinpoint the exact one gene that causes the disorder with its mutation. It's typically, scientists believe it's typically a few different genes combined with environmental factors and hereditary factors that will cause someone to exhibit the symptoms of this disorder. So we're going to focus on the one that has been coming up the most in my research, the one that scientists and researchers believe to be the most associated with Hashimoto's, and that is CTLA4, which is cytotoxic T lymphocyte associated protein 4. Basically what this gene does is it encodes a protein that stops T cells, and we'll talk about what T cells are in a minute, but it is in charge of regulating the immune response in the body. So when this gene is mutated, immune responses can just go all willy-nilly unchecked, and they tend to go out of control. And the first place they'll go is this very sensitive tissue that secretes high levels of hormone, which is, I guess, something that is easily mistakable for cancer or a virus. There's other genes that have been associated with Hashimoto's. There's HLA-DRB1, which is part of the HLA complex. The HLA complex specifically helps the body distinguish between its own proteins and foreign proteins. So when that breaks down, then the distinguishing between the two starts to get a little fuzzy. There's also PTPN22, which is another regulator of T cell activation, but hasn't been shown to have as much of a correlation between the disease. And then there's the TG thyroglobulin gene. Thyroglobulin is located in the thyroid, and it creates thyroid hormones. So obviously, if your TG gene is breaking down, then the hormones cannot be created the way they're supposed to. So this is basically what I said before. It's a complex disease. It requires a combination of several mutated genes to develop. It takes years and environmental and inherited mutations to become symptomatic. So typically the Hashimoto's does not start to exhibit symptoms until patients are in their teens to early to mid-20s. More often than not, it's more common in women than in men, and it's typically in their mid to late 20s that it, starts to manifest. I was 26 when I was diagnosed. I have a friend whose sister was 24. So it takes years. You might have the mutation and never know it until you start to exhibit symptoms further down the line. So we are going to focus on CTLA4. It is a member of the immunoglobulin superfamily and encodes a protein which transmits an inhibitory signal to T cells. So it stops T cells from doing something they're not supposed to do. And T cells, what are T cells? T cells are a major part of the immune system. They are responsible for attacking foreign substances. They are the soldiers of the immune system. So the CTLA4 gene encodes a protein that will inhibit the creation and the response of T cells when it's not warranted. So without that protein, T cells can become overabundant, and this can lead to autoimmune response. It actually is involved with a number of diseases: Hashimoto's, Graves' disease, MS, rheumatoid arthritis, and so on. And what happens is that the gene lies on the chromosome 2q33. There's a picture of it down there. These polymorphisms can cause a missense transition. So these three different polymorphisms have been linked to autoimmune disorders. There's an A to G SNP that they have found to be the most frequent that occurs in people with this disorder, where basically alanine instead of threonine is created. So 75% of Hashimoto's patients have at least one ALA-containing allele. So they're pretty sure that this is the mutation that causes this gene to malfunction. There's also a C to T SNP and an A to T repeat in exon 4. These are all three mutations that can cause this gene to fail. The pattern of inheritance of Hashimoto's is thought to be autosomal dominant. All of the research that I have found has supported this. There is no definitive answer yet as of present day as to the pattern of inheritance because it's unclear. There seem to be multiple factors involved. It's not just one hereditary mutation that follows down through generations. It does definitely run in families. In the one study that I found, they studied 3 siblings, a father and an aunt on their father's side, and they were all affected by the disease. So that their data supported the fact that autosomal dominant inheritance is the tendency for thyroid autoimmunity. But again, it's not a perfect science. It's still being studied. Here you can see a pedigree for Hashimoto thyroiditis. Obviously, it follows down through generations, and it definitely seems to be more specific to females than males. But again, there's still no data that I found for a specific answer as to how it's inherited. Symptoms. So the symptoms are varied widely depending on the person. Over time, Hashimoto's causes slow and chronic cell damage, so it can slowly develop any or all of these symptoms. And of course, like we talked about before, the symptoms of Hashimoto's, although they are predominantly hypothyroid symptoms, so symptoms of low hormone levels, they can also have hyperthyroid symptoms, which are very different, and they vary wildly. So hypothyroid symptoms include depression, weight gain, poor circulation, so you're always cold, muscle aches, fatigue, dry skin, lowered libido, hair loss and thinning, brittle fingernails, and body aches, various other things. Once you start to feel a number of these symptoms at the same time, it's usually a sign that you should get your thyroid checked. Hyperthyroid symptoms, which is the opposite end of the spectrum, that can occur as the thyroid goes into what they call thyroid storm. Essentially, it's dying and it's spitting out random amounts of hormone whenever it feels like it, instead of the normal, regulated, nice, even amount that it's supposed to be giving out over the course of its life. Hyperthyroid symptoms are, as expected, the opposite of hypo. It's an overabundance of hormone, which means your metabolism is spiking much faster than it should be. So these symptoms are sweating, fatigue, irritability, crazy mood swings, and anxiety, panic attacks. The really severe cases can actually have bulging eyes that can occur, irregular heart rhythms like palpitations, insomnia, weight loss, muscle weakness, and lightheadedness. So all of these or any of these symptoms can occur in a Hashimoto's patient. Treatment. So currently there are 2 different hormone replacement drugs that are on the market. One that's a little bit older, which is Armour, and then levothyroxine, or the actual brand name is Synthroid. They're a little different. Armour is natural, so it was made of desiccated pig thyroid, and it was created, I think, 20 or 30 years ago. It's still used today. Endocrinologists tend to shy away from it because it's a little bit harder to control, and not all people react to it as well as others. It contains traces of both T3 and T4. Levothyroxine is a synthetic drug created in a lab, and it only has T4 hormone. So some patients do not respond well to having additional T3 introduced in their bodies, so Armour does not work for them at all. Synthroid is usually what most doctors will prescribe starting out. The drug has to be taken once a day, preferably at the same time each day, on an empty stomach, and then the patient will need to wait at least an hour before eating or drinking anything but water after taking the medication to make sure that the hormone has ample time to absorb into the bloodstream. So the average full replacement dose of hormone is around 100 to 150 micrograms per day. They do this based on the weight of the patient and also the gender. So it's typically 1.6 micrograms per kilogram per day. So a typical full replacement for a woman is anywhere from 100 to 125 micrograms per day is usually all that the average woman will need over the course of her life. It can go up to 150 to 175 micrograms for a male of an average weight, but a starting dose is usually around 75 micrograms. Side effects to this medication will really only happen if the hormone replacement dosage is wrong. So in the beginning, it's going to be a struggle, a process to figure out what the accurate, correct dose is. It's different for every person. And the blood tests will show where your hormone levels are, and that's what your endocrinologist will use to prescribe your drug. But with too low of a dose, hypothyroid symptoms will still persist, and the patient won't feel any better until their dose is upped. And then obviously with too high of a dose, they can feel hyperthyroid symptoms that we talked about before until their body regulates. What to expect? So most patients with Hashimoto's will have to take this hormone replacement medication for the rest of their lives. The thyroid will not get better. There is no thyroid transplant yet. It will continue to get worse. It will continue to fail until eventually it will stop altogether. Hopefully, most patients will recognize their symptoms and will seek treatment long before this happens. And it's a pill once a day. And as long as you keep an eye on your dosage, as it shifts throughout your life, you'll be fine. Blood tests are usually required every 6 to 8 weeks, right in the beginning when you're first diagnosed, to make sure that the treatment is adjusted and the dosage is adjusted so that no symptoms are occurring. Annual checkups are then suggested afterwards. If a woman gets pregnant, she'll need to be monitored very, very frequently, possibly weekly, possibly every other week, to make sure that her blood levels are enough to support both her and her fetus, because your thyroid is supposed to produce hormone for your fetus as well. And there's always some lead time, 1 to 2 weeks after changing the dose, to allow your body to adjust to the new dose, so there will be symptoms until that adjustment period ends. So there's plenty of support and resources for this disease. The American Thyroid Association, there's Hey Hashi, which is a pretty cool group with a blog online that talks about the disease and the disorder. There's a Hashimoto's Facebook group. Any amount of information that you might want about the disease and what to expect and how to get help and how to manage it can be found on any number of websites. And then, of course, your doctor will probably have plenty of other resources for you as well, for not just Hashimoto's, but for other autoimmune disorders. There's specific diets that can help with autoimmune problems, diets that are low in acids, low in what are called nightshades, so low in potatoes, peppers, anything with acidity can actually help with thyroid health as well. Here's a list of endocrinologists in your area that you can look up. And here are my references. So that's about what I've got. Thank you for listening, and I hope this has been informative.